you all know is from Meerut, and Dr. Neeti and Dr. Ruma are from Gangaram Hospital. Yeah. So I would like to start with introduction of our faculty first. Sana, let me share the screen. Okay. So yeah, am I audible? Yeah, okay. So we welcome Dr. Abha Majumdar. She's the director and head of the Center of IVF and Human Reproduction at Gangaram Hospital, Delhi. And ma'am has a very busy schedule, and Gangaram is in the news for so many reasons nowadays. I hope we start testing again in Delhi, because all the doctors, they are getting so panicky about the test being banned, and even other states are scared that, you know, maybe they shouldn't also stop doing the tests. Welcome, Dr. Abha. Our expert faculty has Dr. Jaideep Malhotra. We all know Dr. Jaideep so well. She's a consultant and director at Rainbow IVF. Dr. Jaideep is very actively involved in all FOXY activities. Dr. Jaideep is President ISPAT and SAFU MS nowadays, and she has been immediate past President ISAR. Our last travel was Hyderabad only, when COVID was coming up, and everyone was so scared whether to travel or not. And I think after that, no one has traveled yet. Yeah. Let's hope for good days soon. Welcome, Dr. Jaideep. I'll quickly introduce to our expert panels. I welcome Dr. Anshu Jindal. She's a consultant and IVF specialist at Jindal Hospital and Dr. Madhu Memorial Test Tube Baby Center at Meerut. And she and her husband, both, they love to actively participate in FOXY activities. Welcome, Anshu. Dr. Neeti Tiwari is consultant at Gangaram Hospital IVF unit. And Dr. Ruma Satvik, she's also working with Dr. Abha at Gangaram Hospital. So we are going to have two lectures first by our expert faculty. First of all, Dr. Jaideep is going to share with us my top 10 secrets for ovulation induction. Welcome to Dr. Jaideep. Over to Dr. Jaideep. Sorry.
Okay, can I share my screen?
Sure, ma'am.
Yeah. So hi, good evening, everyone. It's such a pleasure to be with all of you, and thanks, Aarti, for this opportunity. I'm going to, this is a little longer talk, but I'm going to finish it in the stipulated 10 minutes. Rest we can discuss in the discussion sector. So ovulation is not as simple as we think, and is also very simple also. Like, you can tell the difference between these two pictures. And most of the times people say there's a tomato there or there's an apple there. But I would say there's one which is artificially ripened and the other one which is actually naturally ripened. And that is what all ovarian stimulation is all about. The secret number one is that you cannot treat all women like this herd of sheep and say you give the same dose to everyone and they will all respond similarly. It's not going to happen. So we really need to understand the hypothalamic pituitary ovarian axis, and then understand a lot of things, which, you know, how the follicles grow. Initially, we used to think it takes almost about 220 days for good follicular genesis. It still does take, but today we understand follicular genesis happens in waves. So that's why the newer stimulation protocols are now coming in place. Then we do understand the two-cell, two-gonadotropin theory, which is very, very important. We also have to understand the FSH threshold and the window concept, which is again very important as far as understanding about the doses and all is concerned. And the latest thing which has come in our armamentarium is, which we have already seen, and I think we're going to have a case a little later, is on the follicular output rate. Not all the patients who actually look good will respond good. So there is something which is, tricky in there. So let us come to our secret number 2, which is again very important. You have to understand the type and mechanism of the action of the ovarian stimulating agents which you are going to use. So I know that I was going to talk about oral ovulation, so I'm not going to get into it. But yes, whatever drugs you're using for whosoever, you must understand how the drug acts. And that is where you will get the best out of the drug and also of the output. No matter whether it's gonadotropins or agonists or antagonists, we are jumping today from the agonist to the antagonist cycles, and we are all saying that, antagonists, because it's patient friendly, is as good as agonist. But yes, I'm sure there is a place for agonist also in some situations, and that is where we must understand the key differences between the two. Then we come to our secret number 3. Whom are you going to use the drugs? Assessment of the patient is very important. Now, there are so many variables and factors in the patient itself, whether it's age, ovarian volume, antral follicle count, and so on. Along with that, I would also like to emphasize on the preconception lifestyle, because that also affects a lot as far as the outcomes are concerned. So a lot of times, people do ask me that what is it that you would look into? Honestly, I'm telling you, till a few years back, age and AFC was the only thing which I was actually doing. And very few patients I would do, AMH or something. AMH was not that much available also. But today we definitely have added AMH in our armamentarium, but I can tell you I can do without AMH totally. Because if you're good in your ultrasound, and if age is, there are two important things. If you're looking at the quality of the eggs, age is a good indicator. And if you're looking at the quantity, there's nothing better than AFC. But yes, sometimes you may require AMH, especially for documentation purposes, it is important. Another very important thing which we would like is that in younger patients who have normal cycles, you must understand that this FSH rise is just before the menstrual cycle begins. And in the older patients, you see that the FSH rise is much earlier. And when you'll do a day 2 scan, you will see that the follicle size or the antral follicles, which we are supposed to see on day 2, are much larger. And that is where the cycle length is shorter. And that's where the adjustments for older age group patients or, with poor ovarian reserve have to be made. Coming to my secret number 4, stimulation all depends on ovarian reserve. So we actually used to understand, low reserve, you must give a high dose. It's not true anymore now. We need to understand today what is the outcome, and that's important. So for the right patient, you have to choose the right approach. And for that, what is the need of stimulation, whether you're doing IUI or IVF, or you're going to look at fertility preservation. Now, all those things have to be put in place before you choose a protocol. So a moderating approach for high responding women, a maximizing approach for normal responding women, and a creative approach for a reduced responding women is something which will lead you to maximizing the clinical live birth rate. Now we understand a lot differences between the protocols, but I'm just going to tell you here, if you're looking at the pictures like this, where there's smaller reserve, a normal reserve, and a more than normal reserve, and you know that by looking at it only that these are the number of eggs you will get. Now, whatever dose you may give, now if this patient, if you'll give 150 also, or sometimes even 75 HMG also, you will still get about 2 or 3 oocytes. So a larger dose is not really going to make much of a difference. But we definitely understand that if this is what the picture is like, then we don't have to give a larger dose. And that's very important, because even in this COVID times, we need to understand that OHSS needs to be prevented. And that's very, very important take-home message. Coming to my secret number 5. If there's any functional ovarian cyst in the ovary, do not start the ovarian stimulation. And there are plenty of ways where you can, push the stimulation protocols a little forward. and then start at a point when you have the serum estradiol levels which are low and also the progesterone which is low. Coming to my secret number 6, choosing the right protocol. Now, what is ideal protocol? I don't think any one of us has an answer to it. Now, we need to understand that we were talking about conventional protocols. Today, we talk about individualized protocols. Then there were many studies which came up and said, oh, individualized is also not as good. So we went back to some fixed protocols. But any time when we choose a protocol, we must know what is the aim of our stimulation. Whether we are looking at a single oocyte or 6 to 7 or more than 8. And that is where choice of a protocol will actually come forward. Let me just explain to you in another way. Now, here is a patient who's less than 35. I would say less than 33 in our scenario. And we know that euploidy rate in this age group is going to be 60%. So how many actually oocytes are required in a good clinic with a good lab and embryologist for a euploid blastocyst, which will give you a good outcome? You will need about 2 blastocysts, because if you're looking at, one will be normal. You need 4 fertilized oocytes, you'll need 5 M2 oocytes, and you'll need about 6 COCs in this age group to get a good euploid blastocyst. Similarly, now this number as age advances will go up. And we also understand now that in this age group, let's say between 40 to 42, the requirement for the number of oocytes, because the euploidy rates go down from 30% in 39 to 40 to about 20% in 42 years, you will need larger number of oocytes, and that is what you may not really obtain. Now, we have a lot of algorithms where you can choose, the correct dose. This is the one which was probably, very, very popular. A lot of people do use it, which is based upon AMH. I've just converted the AMH picomoles into nanograms for your, easy understanding. And we understand that a high response will come anywhere between, let's say, 3 nanograms up. And antagonist is a protocol of choice for these. I am not going to get into protocols. I'm just giving you some examples on how these understandings can affect. So as I was talking, fixed or individualized, there were a lot of studies initially, conventional and fixed protocols, then individualized, and then we came back to no, individualized don't really make much of a difference. But today, again in COVID, we are understanding that yes, individualized has a place here. Secret number 7, understanding the pharmacoeconomics. In our scenario, definitely yes. And all over the world, if the insurance is also paying, yes, it does make an effect. So because money really matters. And at every stage, if you see, whether it is, stimulation or, coming out with twin pregnancy or reductions and all, it's costing money everywhere. So, and plus, if you're giving a larger dose, it is going to have other implications also, which again will cost money. So we are today coming back to milder stimulation protocols because they have increased safety, decreased cost, and better embryo quality. But one very important factor when we talk about milder stimulation protocols is, which we don't talk, is time to live birth. Now that's important because our patient is worried about 3 important things. One, the foremost in Indian scenario is the cost. Second is the outcome. And the third important thing is time to live birth, which we normally do not consider. And especially in these COVID times, we really need to consider that also. Coming to my secret number 8, modifying responses. Because again, that is important. PCOS, many things where we can modify responses. OHSS, hyper responders, segmentation of IVF cycles is something which will modify the response and definitely decrease the complication rate. Freeze-all, we need to really consider again. And then increasing the response for poor responders. There are again many, many things which are available. I'm just going to sum it up for you. We thought growth hormone worked. Latest studies say growth hormone doesn't work. We thought androgens work. Androgens do not work. We thought aspirin and other things are going to improve the blood supply and they will work. Studies say they do not work. what may be, which has been seen, folic acid supplementation, and yes, vitamin D replete women's perform better. So that is the only evidence which I have right now. So coming to my secret number 9, you have to keep on moving. Like we moved on from conventional to mild to minimal to individualized, and then again now a steady head on our shoulders. We need to constantly keep on updating and experimenting rationally, because once you have some evidence, it changes your practice, and once you practice, it changes your evidence. And that is what we need to understand, and this COVID has actually taught us a lot of things. Last but not the least, there is a learning curve for everything. Nobody knows everything for sure. So we should really make a constant endeavor to understand and keep on updating ourselves and be persistent in a learning process, which is very, very important. Like this dual stimulation or random start protocols, or the many protocols which we now were using for fertility preservation, we have started using for poor responders now. So, these constant things which we keep on experimenting and documenting are going to make us learn a lot of things. So, I would say if we do this, the end of fertility may be soon in sight. So, thank you very much for your patient hearing. And I think I am well in time, Aarti. I haven't taken too much. Thank you again.
Thank you. Thank you. Thank you for lovely tips. Each tip is worth $1 million, because induction of ovulation, the fertility specialists have been doing for ages, but every few months, I would say, there is a change in the trends, and one has to keep trying. One should not give up to get good results. Now, our next speaker is Dr. Abha Majumdar. Dr. Abha is going to talk on my approach to difficult situations in ovulation induction. I would invite Dr. Abha to share her screen.
Thank you very much, Aarti. And I had been made to understand that this forum is for general gynecologists.
Yes, ma'am.
And we were not discussing only with IVF specialists. So I've made my presentation very differently. And I've made it in terms of ovulation induction, the difficult patient.
Yes.
So I hope we'll be able to sync in with everyone. Can you see my slide and can you hear me?
Yes, ma'am.
We can hear you. You have to speak a little louder, ma'am.
Okay, you want me to speak a little louder after Jaideep?
Yeah.
I have to raise my voice. Okay. So what I'm going to speak is on approach to difficult situations in ovulation induction, and this is purely for a gynecologist. It is for a practicing clinician who's sitting in a clinic not doing IVF, and these are non-ovulating patients who have to be managed. I'm sorry I didn't bring in the simple things like clomiphene, letrozole, because I thought that I don't have to deal with. I'm only looking at difficult situations. So let us look at a few difficult situations in ovulation induction. One thing is, a PCOS woman comes, you give her clomiphene or you give her letrozole, she's ovulated, your problem is gone. But if she's not ovulated, she becomes a difficult patient in ovulation induction, and then we may have a difficult PCOS, which you've diagnosed to have. It could be a difficult hypogonadotropic hypogonadism, and it could be a case of hyperprolactinemia also, who would present with some difficulties in ovulation. I'll deal just with these three indications. What are the challenges in PCOS? Well, one is that they respond to small or standard doses of clomiphene, or in today's world, I'll say clomiphene or letrozole. Two is that they have an exaggerated response to clomiphene citrate. You give them 50 or 100 milligram and you find 4, 5, 6 big follicles forming. Then there is a group of patients where there is no response to clomiphene, and this is clomiphene resistance, even to the increasing doses. And then they respond or hyper-respond to small or incremental doses of gonadotropins, which is given. So once you reach this stage, you know that you've given gonadotropin and they have possibly responded. Then there is another subgroup where they have no response to incremental doses of FSH. And last of all, if these patients are further treated, they respond, but they hyper respond to high doses of FSH or HMG. Okay. So how do we use gonadotropins, and what is the starting dose in PCOS women for ovulation induction? Can we monitor without ultrasound? This is my first thing which I put up to my audience, to all the gynecologists who are here. We have to remember PCOS means low dose regimen used in a step up and step down sequential regimen. So you use doses like 50 units or 75 units, never greater than this. Even 37.5 will do. And ultrasound monitoring is a must. You cannot do a gonadotropin stimulation in a PCOS woman without ultrasound monitoring. And they fulfill two essential requirements for successful ovulation induction in PCOS. They allow slow rise of serum FSH levels to just above the FSH threshold level, which is quite high in PCOS. So they have to cross that threshold and a follicle will emerge. But the moment they jump up the threshold, many follicles will emerge. So we have to avoid explosive ovarian response because of extreme sensitivity of follicles to exogenous gonadotropin. So these are the two principles we have to keep in mind when we are dealing with gonadotropin treatment in PCOS women. Now I'm just showing a practical picture that we have started gonadotropin, and I like to use recombinant gonadotropin because we can give it in doses smaller than 75 international units, which I generally do for PCOS, 50 units from day 3 into 5 days. This is the first flat prescription for all patients, that 5 days they would receive 50 units of FSH. Do a monitoring, see the endometrium is shed, it's a thin line, and it is a PCOS ovary. Then you come to day 6 of stimulation, may it be day 7, 8, 9 of the patient cycle, doesn't matter. The day you start is day 1 of stimulation, and after 5 days, it is 6th day of stimulation, where you could find a dominant follicle emerging. Now, more close monitoring is required, maybe 2 days, maybe 3 days. You give the same gonadotropin dose, don't increase the dose because this follicle will grow. The moment it reaches 15 millimeters, you can stop giving gonadotropin and ovulation will follow. All you need to do is timed intercourse for your patient. And in case you plan the IUI, then you give a HCG and plan the IUI. So this is in a resistant clomiphene or clomiphene failure patient where clomiphene has not worked, it has not caused ovulation, or it has failed to achieve a pregnancy in the patient. Then we come to the difficult patient. What do we do here? Same thing, daily injections, FSH 50 units, 75 units, day 3 with slow increments. This is a PCOS with AMH of maybe 5, 6, 7, 8 nanogram per ml. And the same thing is done as you've done in a normal patient. Now, after 6 days, you see that there is no follicle which is coming up. All right, let's wait and see. After every 3 to 5 days, we go on doing ultrasounds, we go on seeing, and after 18 to 25 days of incremental doses of FSH, there is no increase in follicular size or in the estradiol levels also. When follicle sizes don't increase, then we start getting nervous. What is happening? It is 20 days of giving gonadotropin, and we've increased the dose 3 to 4 times every 4-5 days. So we also like to do a estradiol level because endometrium is also not growing, follicles are not growing, and E2 levels are also low. So this is possibly that resistant PCOS which will not respond to low doses of gonadotropin in small increments. So anovulatory PCOS with high AMH, with high BMI, I'm showing you what happens in these patients. We start with incremental doses of 25 to 50 units of recombinant FSH every 5 days, give it for more than 21 days, and we find nothing is happening. What are the problems in these cycles? Follicles do not increase in size, nor the E2 levels. Endometrium continues to be low, so much low that even the patient may face a little bleed in the middle, and you don't know what to do. So injections you've given already for 18 to 25 days with no change seen, and then you think, okay, I have to do something, and you give a big dose like 225, and a hyper response is there when we jump up the dose. But Before this, the confidence of patient and clinician goes down, and if hyperresponse happens, then again the cycle is doomed, because there would be multiple dominant follicles, and you will not be able to let her ovulate or not allow the patient to have sexual intercourse because of the risk of OHSS and the risk of multiple pregnancy. So the challenge is that we do understand there exists a definite group of anovulatory PCOS who appear to be resistant to ovulation induction, treated with small incremental doses of FSH over time for the purpose of ovulation induction. I please stress the word ovulation induction here. I'm not talking about IVF patients where we want multiple follicles. I'm talking of a normal patient who walks into a gynecologist clinic wanting just one ovulatory follicle so that she could get pregnant. And we keep wondering whether it is obesity which leads to this type of a resistant gonadotropin, gonadotropin resistant PCOS, or is it high AMH levels, or is it high LH, or is it high androgen? So I thought that I will collect all my cases and do a study. And so this is a series of 18 cases of clomiphene resistant and ovulatory women with polycystic ovary syndrome and altered response to FSH stimulation, which was published in the Journal of Fertilization in vitro IVF worldwide. And if you see here, look at the characteristics of these patients. The BMI was high for all. A BMI of 33 as mean BMI. Waist circumference of 108 centimeters, AMH in picomoles of 106, which would be almost like more than 10 nanograms. So the AMH was extremely high for these, but otherwise the LH, the lipid profile, the ovarian volume, antral follicle, anything did not make difference. Yes, all women were hirsute. So why don't some PCOS respond to exogenous FSH when administered in appropriate doses according to their AMH? One reason is that very high AMH has an inhibitory effect on follicular recruitment. It's sitting like a monster over the follicles. It would not let FSH act unless FSH really fights back in high doses. The serum levels go high, and then it can slap the AMH back to let the follicles grow. So 2 is possibly FSH receptor polymorphism, which makes follicles resistant to lower doses of FSH. And because these receptors have a change in their um, in the uh, peptides or amino acid chain, maybe a glycine is changed with serine or cysteine is changed with alanine. So there are some changes in the receptor. So FSH molecule receptor and these receptors don't fit very well. So a higher dose of FSH is given to be able to hit on these receptors to show an effect. So lower doses don't work if there is polymorphism. And but there is good news for IVF clinicians with these patients. Why? Because even if the AMH is very high, even if there is FSH receptor polymorphism or 5-beta LH gene mutation, it can be overcome by starting with high doses of FSH or HMG, which in IVF we do. We always start with 150 units and we go up to 225 easily if we don't get a response in 5 days. So AMH is inhibited very fast or the polymorphism is overcome very easily. So this is one thing which I want all of us to understand, that you will encounter some patients where you will have difficulty with low dose incremental doses of FSH or HMG, and these patients will probably respond to high doses, but then they will explode. They will have too many follicles, and you may have to sort of, you will not be able to salvage the cycle except for the few things that you aspirate the follicles or you make her IVF patient. So maybe if 1 or 2 cycles go on like this, these patients are better off for IVF, where they stimulate, the embryos can be frozen and one embryo transfer can be done. So we can prevent OHSS as well as multiple pregnancy. I come to the next difficult problem, which is hypogonadotropic hypogonadism. Well, I'm not going to deal into how to diagnose. We all understand FSH-LH has to be low. You all agree? FSH-LH has to be very, very low in a non oral contraceptive using patient, or we have to stop oral contraceptives for a month or more than that and then do a basal FSH LH to see. Then how to treat, which drugs and doses, we all understand we have to give combinations of FSH and LH, that is HMG. Doses have to go on. How long? There is no limit to how long, and this is what I wanted to bring here. I will tell you why. Because I was referred hypogonadotropic hypogonadism patients for oocyte donor IVF. All I had to do is give them a little longer gonadotropin, and I still remember one patient who conceived. Any pre-treatment? Yes. The uterus and endometrium has to be primed with HRT, mainly estrogen, followed by progesterone, so that the endometrium learns to grow, and luteal support is mandatory. HCG is a good option. Now, I want you to just know that even hypo women have two distinct subgroups, which is distinguished by AFC and AMH. Hypogonadotropic hypogonadism can be present with small ovaries with negligible AFC and a very low AMH. And there could be one hypo group where we see a almost polycystic like small ovary, which has many follicles, small ones, and an AMH also, which is reasonably good. I have seen high AMH also in such women, but reasonably good means 1 nanogram, 1.5 nanogram. And there is a very good response to ovulation induction um, in these women. Those who have polycystic like ovaries, they also have an exaggerated response to HMG or gonadotropins whenever they are stimulated. So keep this in mind, that hypo can have very small ovaries, they can have normal ovaries, and they also could be hyper responders like PCOS. You might encounter all these, and a pre-diagnosis can be made by their AMH and looking at their ovaries. But I wanted to bring this case to you where the patient had an AMH of 0.65 picomoles, which means lower than 1 picomole. This is 1/7 of a nanogram. And after priming, she was given 102 days of stimulation with gonadotropin, and that is when a dominant follicle formed and she got pregnant. This is like prolonging it too much. 102 days is a lot. But all I want to bring to your attention that these girls easily take 30-35 days. Don't give up on them. Continue stimulation. If your diagnosis is correct, you will get a dominant follicle. Last, I thought, was hyperprolactinemia, which is another problem which comes with anovulation. There are two special situations with hyperprolactinemia which I want to bring here. One is a 32-year-old infertile woman with menstrual cycles ranging from 28 to 32 days. You confirmed ovulation by day 22, serum progesterone, which was over 8 nanogram per ml, serum prolactin persistently over 50 nanograms per ml on 3 occasions. What will you do? I want all of you to answer in your mind, what will you do? You will start cabergoline, you will start bromocriptine. What will you do? You will do nothing. She is ovulating. This hyperprolactinemia is not pathological. It could be the big prolactin molecule which is showing in the bioassay, but it is not causing ovulatory disorder, so she needs no treatment. One more case. Mrs. R wants to travel out of the country in 3 weeks. She wants to have treatment for anovulatory hyperprolactinemia and ovulate before she leaves. Now, which is the drug which you can give that within 3 weeks you can ensure that she's ovulated? I don't think bromocriptine or cabergoline could work so fast because it takes almost 4 weeks to start ovulation and then another 2 weeks for menstruation to come. So what will you do? Well, how can you treat her? HMG or a combination of FSH-LH. So gonadotropin is the answer. You forget about the hyperprolactinemia. It's only creating a hypo condition for her. So all you have to do is treat her with one of these two drugs. So now I end with the last word to ovulation induction. If the diagnosis is correct, most cases will ovulate. Aim is not to achieve ovulation at the cost of increase in complications, and we all understand OHSS, multiple pregnancy, are two dreaded complications. Days taken to ovulate, whether she is PCOS, whether she is hypo or she is hyperprolactinemia, do not matter. She can ovulate on day 60 also, but that ovulation can lead to a pregnancy. And the last is ovulation induction is not only a science, but a piece of art. With this, I thank you all for listening to me.
Thank you. Thank you, ma'am, for the beautiful lecture. And yeah, we can stop sharing the screen, ma'am.
Yeah.
Thank you. Thank you so much. Beautiful pearls of wisdom. and very tricky cases which everyone comes across every day, and sometimes you don't have such simple answers to all of them. Thank you. I'm sure all the viewers must have got very good pearls from both our senior speakers. Now we would like to take clinical presentation. Our first case will be presented by Dr. Anshu Jindal. And first, she is going to tell us about the clinical presentation. Then we'll discuss the management policy.
Yeah.
Over to Dr. Anshu.
Thank you. Thank you so much. Lovely presentation. Both of you, ma'am. Lovely. It's really great.
मुझे पानी चाहिए मेरा मुंह था
Last slide. This is the last slide. First. Yeah, thank you. Thank you so much, Aarti, for giving me this opportunity of presenting this very interesting case. This patient K, 33-year-old, she came to us with primary infertility, married for 10 years. Her menstrual history was absolutely regular, 3 to 4 days, and 27 to 28 days, regular cycles. She gave history of hypothyroidism. She was on 50 microgram Eltroxin for the past 3 years. And she gave history of hypertension as well, managed very well on medication. There was no history of tuberculosis or diabetes. On HST, she had bilateral corneal blocks, which was diagnosed around 3 years back, for which she took some Ayurvedic treatment for reasons best known to her. So when she came to us with this diagnosis, and she was very keen for a laparoscopy, hysteroscopy, and we really thought that maybe we should open up our tubes. She's just 33-year-old, and follow it up by IUI or whatever. So we did a laparohistro for the patient for her bilateral corneal blocks, and we were able to achieve a patency with Novichok's cannulation. Her ovaries appeared normal. There was no evidence of any adhesions or endometriosis, and all tests for TB were negative. And post laparoscopy, she underwent 2 cycles of IUI with gonadotrophins. 75 units, international units in the first cycle, increased to 150, wherein she ovulated with a good endometrium response, but both the cycles of IUI failed. Her investigations were something like this: FSH 8.6 milli international units per ml, LH was 3.5 milli international units per ml, prolactin normal limits, TSH was quite well controlled on Eltroxin 50 microgram, as I just told you in the history. Her AMH was low, around 1.3 nanogram per ml, and on ultrasound on day 2 scan, she showed 5 to 6 AFCs considering both the ovaries. Her semen qualitative analysis of her husband was quite normal. So after 2 failed IVF cycles, the patient decided to take a try for IVF ICSI. And in the first ICSI cycle, considering our AMH was 1.23 only, we decided to stimulate with 225 units of HMG from day 2 with the long agonist protocol, which was increased to 300 international units on day 5, when she showed a little poor response with just 4 small developing follicles. This was continued, and we managed to retrieve 4 M2 oocytes for this patient, and we managed to transfer 3 fresh, it was a fresh embryo transfer of 3 grade A embryos, but the cycle failed. In the second IVF cycle, she was not willing to wait for too long. She wanted the second IVF cycle in quick succession. So we decided to take her up for the second IVF cycle, but this time we decided to use recombinant FSH for her. And we started with a dose of 300 international units from day 2, again a long agonist protocol. And we managed to retrieve 3 M2 oocytes, only 3. So she was definitely a poor responder. And we did a fresh embryo transfer of 2 grade A embryos. The patient conceived in the second ICSI cycle. She had PIH, hypothyroidism in pregnancy, and she had APLA syndrome as well as positive, which was diagnosed in the first trimester, and which was managed with low molecular weight heparin throughout her pregnancy till till term, and then she delivered a healthy baby girl of 2.6 kg at term by cesarean section. So she was here. I present this case of a poor responder who was into the who falls into the Poseidon group 3 because she was having low ovarian reserves, but actually borderline ovarian reserves. She was less than 35 years, so she is falls into group 3 of Poseidon according to the criteria, Poseidon criteria. So now we can discuss this case, and if you want me to discuss the management, then I can go ahead with my slides. How do you want it, Aarti? You want me to discuss on?
I would like the opinion of the how.
I think I'll stop my share and I get back.
So I would like Dr. Jaideep to comment, like what else could we have done so that, you know, we could get a better result in this earlier. Yeah.
See, basically what I'm thinking right now is that, I don't know, I mean, I would have thought of increasing the dose of HMG itself. If I was just thinking poor responder and the dose, especially if it is fought, which when you say follicular output ratio is lesser than what we are seeing. I mean, so I would have increased the dose of HMG if I would go with a mindset based on poor responders do better with HMG. But now when you're presenting this case, I'm just thinking that maybe, you know, the polymorphism was there and maybe FSH dose increase has helped, but actually it hasn't helped, honestly speaking, because last time you got 4 oocytes, this time you got only 3.
But she managed to get pregnant, ma'am, and we went to the recombinant. We went to the recombinant in the next cycle.
I would have also thought of TPO, because that's also again important. But then when I'm just looking at your results like grade 1 embryos, because if TPO was high, then the embryo quality and also maybe the oocyte quality is also not good. So
TPO was normal,
I can't reach a conclusion in this particular case. Abha, you want to comment something here?
First thing is, I don't think this is Poseidon 3.
Why, ma'am?
Poseidon 1, because the age is 35, AMH is 1.
33, ma'am, 33. She's 33.
33. Then she comes to Poseidon 1. Right?
Yeah.
She had a low response, but this AMH comes into the normal range. 1.2 is normal.
Yeah.
I think you did the right thing. A long protocol works well.
Amma, can you speak a little louder?
Oh, really? Am I?
Yeah, can't hear you.
Yeah. Am I muted?
No, we can hear you, ma'am.
We can hear you very well, ma'am, now.
Yeah.
Okay. All I want to say is that I don't think what you did, anything needs to be changed. A long protocol is nowadays recommended.
Yeah. Better yield of eggs.
First cycle, you find a poor response. Then you say it is Poseidon 1, and then you could do anything like adding androgens or increasing the dose or looking at all the factors. That was it a trigger problem? Was it stimulation problem? Was it trigger problem? Was it aspiration problem? And if nothing was there, then just increasing the dose in the subsequent cycle, what you did. And look, long protocol is very much in place for such poor responders because it makes the cohort better for patients.
Yeah, that's true, ma'am. You get a better number.
Maybe antagonist protocol with a higher dose, because that's the only thing.
Because increasing the dose did not increase the number of oocytes. Yeah. That is one this thing, you know, when we say polymorphism, and because your follicle output ratio was lower last time, it would have improved this time if there was polymorphism. So polymorphism is not there, according to the history.
I want Dr. Ruma and Dr. Niti's opinion.
Yeah. So, am I audible?
Yeah.
Okay. I don't see a conflict anywhere with the management. Your AMH perhaps on the borderline,
absolutely,
or 1.2 is enough to whatever category it is in. It requires stimulation with a higher dose, which you started with 225.
Yeah.
And thereafter, you attempted, and since the cycle failed, you attempted to increase the oocyte yield by improving on the gonadotropin dose, which you did.
Yeah.
Also, the type of gonadotropin, which you changed from from HMG to recombinant.
The next cycle, yeah.
Yeah. So see, all cycles are not going to be alike. First of all,
Yeah.
we need to understand that. It is not necessary that we increase our dose, necessarily the oocyte yield has to improve. And the difference lies in how many follicles are recruited per cycle. It could be 4 in this cycle, it could be 7 in the other. This is irrespective of what you are doing yet. This is before you start intervening. So 3 or 4, according to me, doesn't make a difference. She got pregnant, and my only question to you was with respect to the management of pregnancy. At some point you said there was APLA diagnosed in the first trimester. How do you do that? How do you diagnose?
We did the whole APLA syndrome, panel syndrome, and we do the APTT and the anti-cardiolipin antibodies, which were very high for this patient, and she was put on low molecular weight heparin for that.
Why did you do that in the first place?
Before
APLA?
I didn't do it before, ma'am.
Why did you do it?
I do it routinely in all my antenatals.
Huh?
What's the question, ma'am? Why did you do APLA?
Yeah.
I do it in all my antenatal high-risk patients, and even otherwise, I do an anti-cardiolipin antibodies, because we never know.
What made her high risk?
She's IVF patient. She's 10 years married. She's desperate. She's tried everywhere. She's come to me with a big hope. And any IVF patient is a high-risk pregnancy, according to me, because it's every pregnancy is very precious.
Normal delivery for any IVF patient if they are all high risk, or you?
I used to do normal delivery when I was not doing IVF. When I started doing IVF, it was all 100% cesareans. I have delivered IVF. Somebody else's IVF.
I can't get over this one question which is lingering on in my mind is that what made you, start with HMG, I can understand, but what made you switch over to FSH in the second cycle?
Yeah. Ma'am,
in a poor responder, what you thought is a poor responder?
Yeah, because I thought sometimes the efficacy of the HMG is not good enough, ma'am. And you are giving a particular dose, but you don't know whether really you are giving the right dose or not.
But then why not a combination of a recombinant FSH and LH in the second cycle?
Yeah. This is what even I was thinking, that she could have thought of giving.
Why?
Because see, HMG I can understand. Like I want to ask you now, if I can. I don't know, because it might be beyond the thing. Which HMG? What combination or which HMG were you using?
We were using Bharat Serums, ma'am, HMG in the first go, and we used the recombinant. If I can recall, I think we were using. Can't recall the.
No, these are very important things to understand, because there are many kinds of HMG available from all companies. So what we are using is also very important, whether it is a reputable, cold chain maintained and
absolutely,
all.
Ma'am.
Yeah.
Absolutely. I would agree with that.
The only thing which you did, all the things were correct. The only thing you could have added was a little LH when you got a response in the
in the second cycle.
In the second cycle.
But I think it was perfect as what you did. I don't think there are any controversies in what you did, except
and all well that ends well. She delivered a healthy baby in spite of all odds. So I mean, it was the right management. In other words.
No, actually, I don't really say this, because even if you had done the same thing
again
in the second cycle for the same patient, she might have still conceived.
I think I agree with that.
We have to understand what better did we do in this cycle. I mean, I can go on and on discussing this, but what better did we do in this second cycle?
Actually, the number of oocytes, were similar only.
Exactly.
Almost decreased.
So it is just one odd chance that she would have gotten pregnant in the second cycle of the same dose.
I would agree with that, that even if I had done the first thing, what I did in the first cycle, maybe she would have conceived. It was just by chance she didn't conceive in the first and she conceived in the second.
So the lesson learned from this is that we cannot draw conclusions based on one odd case.
Yeah.
You need an RCT to prove a lot of things, which is next to impossible.
That is very difficult. That is where we really don't fare too well as it is.
Can we start with the next case now?
Thank you. Thank you so much. Thank you, ma'am.
It was an interesting case.
Much loopholes, except the apla doesn't go down my throat very easily.
Why don't you do that for ma'am? Just
no. Yeah, let's clarify this, Dr. Anshu. APLA is not recommended in your case. APLA should be done if you have a history of recurrent miscarriage. Actually, 3 abortions, if not 2.
I know that.
No, you cannot.
But in all high risk, I think we should be doing APLA.
No. APLA doesn't fit. Unfortunately,
she came as anticardiolipin positive, ma'am, and she had to be given low molecular weight heparin throughout. She had IUGR. She had all the problems associated with it.
Yeah, a lot of clinics they put their patients on low molecular weight heparin. All IVF pregnancies, they would be loading their patients with support, which is actually not.
Let's give this message across to our audience. Let's not give this message across that all IVF patients should be screened for APLA and they should be put on low molecular weight heparin and aspirin. No.
Even when we don't do a APLA during pregnancy, it is generally done before pregnancy because the values change in pregnancy. And that is why even after pregnancy ends, it is not advised before 3 months of an end of pregnancy because we do not get the correct values of APLA, and especially anti-beta 2 glycoprotein can be found raised in these women for up to 3 months.
And ideally, two readings should be positive at the gap.
I know. I guess theoretically yes, but sometimes
we can choose this case. Everything is good, which ends well. Your patient delivers, and very nice. And we go on to the next case now.
Thank you, ma'am. Thank you so much.
Switch over to case 2. I'll invite Dr. Neeti, and she's going to discuss with us another challenging case. Let's see what she has to share with us.
How come? Okay. So, can you see my screen now?
Yes.
So, good afternoon, everyone. So, I'm here to present a case of a 32-year-old lady who came to us with primary amenorrhea. She was married for 3 years and she was willing to conceive. She used to get withdrawal bleeding only with 21 days hormonal pills, which she took off and on. And because she wanted to conceive, she left them and she became amenorrheic for last 8 months. There was no significant past medical or surgical history, and there was no significant family history. On examination, she was a young adult woman of average build and nutrition. Secondary sexual characteristics were well developed. No thyroid enlargement, no galactoria, no abdominal mass or scar. And pelvic examination revealed a small and mobile uterus with no adnexal mass. On investigations, her thyroid and prolactin were normal. Serum FSH and serum LH were way low than the normal range. The estradiol level was also lower side, but AMH was in the normal range, 1.4 nanogram. Ultrasound pelvis revealed a uterus which was smaller in size with endometrial thickness of 2 millimeter, and bilateral ovaries showed few antral follicles. We did an MRI head also in her to rule out any pituitary tumor or any space occupying lesion there, and was normal, and husband semen analysis was normal. So we made a diagnosis of type 1 anovulation, that is hypogonadotropic hypogonadism. So as Dr. Abha has already told us about the management of hypogonadotropic hypogonadism, because this lady was not taking HRT for last 8-9 months, we had to first prime her uterus. So we gave her 3 months of sequential estrogen and progesterone withdrawal. And after that, the ovulation induction was started with HNG. We started with 75 unit and gradually kept on increasing it to see a follicular recruitment. But unfortunately, the follicular recruitment did not happen. We went up to 450 unit of HNG over 23 days and still no follicular recruitment. So the first line of management in the hypogonadotropic hypogonadism, that is HNG, did not work for her. So what would be the next management for her? So this is the question to the panel. I will stop sharing and we can discuss it. So Dr. Jaideep, if you could suggest us something in this patient, ma'am.
You know what? I look at the profile of the patient. First of all, I never get a patient who will take a FSH or HMG for 23 days.
Okay.
You know, you have to understand that, and they don't have an insurance. So after about 7 to 10 days of, let's say, between 225 to 300 units, if I have given, HMG and there's no response, I would actually start counseling her for egg donation. Honestly, I'm telling you. By the way, in between, we always see that with all that, whether her estradiol levels were going up or no, how was her endometrium looking on ultrasound scan, which actually gives me a clue what was the follicle size, what was the antral follicle count.
So I'm sorry if I forgot to mention this, ma'am, but the estradiol level we did monitor and it was not going up. So that is how we knew that actually nothing was moving.
So here, I have been referred such multiple patients. Almost 10 patients came with the plea of going in for donor egg IVF. And I think 80% conceived without IVF. Not only hypo, also hyperprolactinemia. Because you need a lot of patience to go on with this. Ruma, would you want to throw some light on?
But she had no hyperprolactinemia.
Jaideep said she would.
No, she did not have. It was an idiopathic.
She did not have hypothyroidism, which I checked.
So Jaideep feels that she would not go further and she might think of oocyte donation. What would you do?
Because see, when I'm following it up, I'm looking at many things on scan and I do my own scan. So it actually gives you a lot of clue on how this patient is, the blood flow of the ovaries, how the endometrium is responding. I normally don't even do estradiol levels because your endometrium will show you whether the estradiol levels are rising or not rising. So it does give you, plus we are into private practice. This patient is not supported. So it is criminal if I keep on, telling her to take 450 units. My patients are not so rich. Take it for 23 days and then say, okay, abhi kuch nahi kar sakti.
Your patients can have IVF with donor eggs, but they can't take gonadotropin.
No, 450 for 23 days is a lot of HMG.
No, ma'am, we reached.
And no response.
Sorry, ma'am, but
no response.
Yeah, we gradually reached that level.
If I may,
gradually reached that level.
So it's a lot of HMG.
Give your opinion.
So, but again, I would say here, if polymorphism is something which I'm, thinking about, maybe recombinant FSH and recombinant LH is something which in the last 4 or 5 days I would have tried.
Just one little point here that
before giving it up if she's affording.
There's just one little point here that a woman with hypogonadotropic hypogonadism has never been stimulated with FSH. And if we understand the physiology of folliculogenesis, it takes about 2 months for FSH dependent phase to get over. So there is a prior follicular priming that is happening at a very low level of FSH, but not, this woman doesn't have high enough FSH to cause that priming. So that priming might take longer. What we would typically see in women who are being stimulated for the first time is that the durations of stimulation are longer. The second cycle, it is shorter. The third cycle, it is what you want it to be, and she would ovulate with much smaller doses. So I think the message here is that you wait patiently for a longer duration of time, maybe with the same dose, because the initial dose is just causing the first 2 months of follicular priming. And this later doses are actually causing folliculogenesis the way you see it on ultrasound. The way you see it move from 4 mm to 18 mm, that is happening in the later part of the stimulation. So initial stimulation is just for priming of that follicle.
Dr. Anshu, do you want to say anything? You have to unmute yourself, Dr.
sorry, I'm so sorry. I wanted to ask you whether you gave her HRT prior at least for 3 months prior to.
I did that.
How much dose of what dose did you use? How did you go about it?
Normal
we started
HRT,
with
which
the
is
normal HRT cycle, which we start with Progenova, and we
many?
build up the endometrium.
Yeah.
And
how
we
was
build
the
up to
response? How
very
was
nice.
the endometrial response that time?
Very nice, very nice. We monitored it in the first cycle, and it reached 8 millimeter, and then we gave added, meprate to it.
Achha.
The medroxyprogesterone acetate was added. The first cycle was monitored, and after that we could give it without ultrasound also. So 3 cycles were given.
3 cycles.
And she showed good response.
She showed good
now
response.
let us see what you did for this patient, Neeti.
Yeah, let us see what you did.
Yeah. So
share your
let
screen
me come back to this. So what we did was that why I'm not able to move it. So in the same cycle, after 23 days, we switched to recombinant FSH 150 unit and recombinant LH 75 unit in 2:1 ratio. And to our surprise, after 6 days only, 2 dominant follicles developed, and which ovulated following HCG trigger. And patient was advised timed intercourse, and she conceived twins in the very first cycle. This is a case report which we have sent for publication also. So just to discuss, hypogonadotropic hypogonadism is characterized by low or undetectable levels of FSH and LH, leading to failure of gonadal function, which Dr. Abha has very nicely described. Yeah. The first line of management is ovulation induction, and it is done with HMG usually, in which both FSH and LH activity are in the ratio of 1:1. What is important to know is that it takes time. It takes time to induce ovulation in hypogonadotropic hypogonadism. Hence, prior counseling of the couple and patience on the part of the clinician and the patient is very, very important. HMG is usually started at lowest dose because we don't know how the patient is going to respond. And 75 unit, we normally give it for 5 to 7 days. And then they are increased in the doses of 75 unit only. So after 75, we'll make it 150, then 225 every 5 to 7 days. And as soon as the follicles start appearing, we continue at the same dose. We cannot expect a hypogonadotropic hypogonadism to respond in the same way as our other patient, where the stimulation happens in 7 to 10 days of gonadotropins. So the gonadotropins should not be stopped even after 20 days. And the longest duration reported in literature is 102 days, as Dr. Abha had just described. Urinary gonadotropins at times fail because they have an inconsistent action with batch-to-batch variability. Recombinant products, on the other hand, have more consistent action. An Italian study compared HMG with recombinant gonadotropins in 70 patients with hypogonadotropic hypogonadism, though they found similar ovulation rate but significantly higher pregnancy rate in recombinant group. So what I'm suggesting here is that HMG is usually the first choice for ovulation induction in hypogonadotropic hypogonadism, as it is a cost-effective gonadotropin. But if it does not work, recombinant gonadotropins can be tried. And what is important is that the first line of management for hypogonadotropic hypogonadism is ovulation induction only. Most of them will conceive with ovulation induction with timed intercourse or IUI if the semen parameters and tubes are normal. IVF is usually required for tubal factor, male factor, or of multiple cycle of ovulation induction fail like any other woman. So please don't jump to a donor oocyte in hypogonadotropic hypogonadism. Let us give them a chance to conceive with their own eggs. So that was the message which I wanted to give up with this case. Yeah. Thank you so much.
That's a very...
I totally agree with you, Neeti.
Thank you, ma'am.
You know, the message which we are giving here, because I'm so happy that, that is exactly what I would have done before giving it up, but not after such a long time. But the message which we are trying to now, if I was a participant, what I would have understood, that HMG quality,
could be
both the cases. So we really need to understand that we have to pay attention to what we are buying, how it is being maintained, and a lot of more issues, because the same could have been true in your case also. That this patient did not respond, and maybe the quality of or the efficacy of HMG was also not good.
True.
Ma'am, somehow understand this.
I feel
which happened over the...
So that is why another important thing which I would say, which I always do, and this has been done in my practice all the time, once I buy a batch, the same batch is used for at least 10 patients, so that we know that the response has been poor or good in all, or
Ma'am,
at least 8 of them.
Somehow the
But
HMG, which is available in India,
research
which is being done in the field of HMG in India is very poor as compared to recombinant products.
Exactly.
The Minopure, which is available in abroad, is such a good molecule of HMG. We don't get similar molecules in India.
Exactly.
So we don't get the desired
cautious.
Because you use a lot of HMG, even in your IVF cycles, your opinion that you found good HMG also. Most of it works.
Yes, of course.
I've been comfortable using it, yes, ma'am.
But I want to ask Dr. Neeti that, like Dr. Abha also said in her talk, that this was a polycystic HH, or was it?
No, this was a normal. This was a normal responder. This is a normal responder patient.
My AMH was
it's not normal
1.4 nanogram.
So in that polycystic HH, you have to have a high AMH levels.
Yeah, you might find a high AMH along with low FSH-LH.
Low FSH-LH is always seen in hypogonadotropin.
It will always be there. So you will find very few patients, in your practice of hypogonadotropic hypogonadism. They are not very common. But if they come, then we have to...
the polycystic ones really hyperstimulate. They really hyperstimulate with any time, like Dr. Abha also said. So I want to ask Dr. Abha that while we are doing their priming with HRT, can we judge whether they belong to on ultrasound, whether they are the small ovaries or the polycystic ones, so that we can prognosticate the patients?
Yes, you can. If the AMH is very low,
how, ma'am?
AMH is in picomoles, maybe 2, 3, 4. We have a lot of hypo patients where AMH is just 2 picomoles.
Okay. And if it is higher,
you see hardly 1 or 2 antral follicles. These patients will take a longer time. You have to prime them with estrogen and then tell them you'll need longer gonadotropins, and HMG makes a more cost-effective preparation in the priming period. 2 is I had sent these 2 cases for publication, which was refused then because I had written as a logical answer that HMG is inconsistent, and we changed over to recombinant, and they responded. They said, no, HMG cannot be inconsistent. Even if you would have used the same drug, they would have responded. And I said, yes, very well. So everywhere, all over the world, HMG is not so inconsistent as it is in our country.
In India, probably the temperatures that we are living in.
No, there are many things.
There are many things to it.
There are many things. I mean, I can't go into the details, but there are many things. And second thing, Anshu, there are priming has many other benefits also.
That is what I wanted to know during priming, whether we can make out, because that is a tricky part. I wanted to know that for the
start, you've done the AMH, you've done the ovarian scan.
By the AMH levels.
You've learned about the case then only, and your counseling starts then to the patient. You will take longer, and they understand. And when you tell them that, yes, you will make a follicle, your confidence transmits to the patient. If you are confident, what will you transmit to the patient? Like Shivani Didi says, you have to have the positive power in you to make the other person feel positive. You cannot...
Private practitioner would know that.
You can't transfer a positivity in the patient unless this right coming through you that you are so positive that it will work.
Yeah, very true, ma'am. Very true.
Okay.
Dr. Neeti's
good case.
Yeah, but
wonderful.
Thank you.
Very good case. The take-home message for audience would be that gradually increase the dose, but I think don't jump up to 450. Maybe normally up to 300 if you keep giving consistently, because we don't want that tomorrow lot of non-IVF clinicians, they are loading.
No, it should not be. 450. No, that message should not go. We reached 450 because there was no response. We have to go in a stepwise manner.
Longer period.
Increase 75 unit.
Jumping and always set an upper limit. Maybe Dr. Abha and Dr. Jaideep can guide that, don't jump up to 450 in every case. It's only very few select cases in which
it was very clear that every 5 to 7 days only. In hypo, you don't wait for more than 5 days. You make from 75, 150 to 225 to 3. We need to go up with Ruma's case. We are at the end of our session. We have only 20 minutes left.
Yeah. So, but Ruma, for how many days did you give 450 units?
Last 5 days only. Last 5 days.
Minimum.
Last 5 days.
Anything. Any dose you change, 5 days is a minimum you should do.
So we gave 450 for the last 5 days and then we gave up. We thought it is not working.
Yeah, very true.
And you got the eggs. Okay. So I'm going to quickly present a simple case. I'll be sharing my screen and yeah. Just 1 second. So this is Mrs. S, 38 years. She was married for 7 years and was on OC pills for 4 years for contraception. Now this lady had been trying for pregnancy for last 3 years with regular cohabitation, but was not able to get pregnant. So her body weight was fine with normal BMI of 22.8 kg per meter square. Her cycles were coming irregularly at the gap of 5 to 6 weeks, irregular with scanty flow. And her AMH level was 0.9 milligram per cent with serum FSH 3.2 and LH 2.12 milli IU per ml. So when we investigated her further, her prolactin levels were 85 nanogram per ml, TSH was 10.6. And on ultrasound, she had a smaller size uterus. And this is day 5 ultrasound, endometrium was 4.2 millimeters. Both the ovaries were smaller, looking with 1 or 2 small antral follicles, but there were no distinct follicles seen. And husband's semen was all right. The total motile sperm count was 30 million with a good motility of about 45% and no pus cells seen. So she had got monitoring done from other centers and no growing follicles were seen. She had patent tubes. Now this lady of 39 years with irregular cycles, my question to House is, how would we proceed for her management?
I think you tell us your management and then we'll comment.
Okay, okay. So, ma'am, we investigated her further. So we got her CT scan done because prolactin levels were high and she had pituitary microadenoma, 6 millimeters. And then she was put on cabergoline bi-weekly, 0.25 milligram, the standard dose, and her thyroid levels were corrected. And we waited for her prolactin and TSH levels to come normal. And then we induced her. We induced her with HMG. And as discussed earlier, we gradually increased her dose, started with 75. This was her first cycle only. And then day 7, we increased it to 150. And on day 19, we got 2 good follicles because she had been trying for so long. So we gave her recombinant HCG for induction of ovulation. And we did her IUI, and thankfully with all the average reports, like which would have tempted some other person to refer her for IVF, she conceived in the same cycle and she was blessed with a healthy baby at full term, and thankfully she delivered normal also. So with this, the take home message is that first of all, we should try less flow, irregular cycles, especially age 39 years. And if her levels are not good, we should not jump on to ART. We should try to work them up. And first, we should try to find a cause. Like hyperprolactinemia is a very common cause, which again can cause hypogonadotrophic hypogonadism, which can cause more levels of FSH and LH and may give anovulatory cycles. So over here, I've just discussed the common causes of hyperprolactinemia just for the audience interest. It is idiopathic in 40% cases, but there may be some tumor like craniopharyngioma or meningioma. Other causes are uncommon. And in 25 to 30% cases, these are functioning tumors only. And macroadenoma, as we know, it's more than 1 centimeter. Sometimes they also respond to treatment, but most of the microadenomas less than 1 centimeter, they respond to the treatment and we get good results. We have to rule out other uncommon causes like tuberculosis, sarcoidosis, and Cushing's disease. And we all know hypothyroidism is a very common cause of hyperprolactinemia, and a lot of times because of the sharing of the molecule, we get to see hyperprolactinemia and hypothyroidism together. And once we rectify them, our patients, they conceive pretty fast. Quickly, I just wanted to highlight that how raised prolactin works, because it's very, very important to check prolactin on first visit of any infertile patient. It affects the GnRH secretion, and it reduces the pulsatile secretion of GnRH and causes decreased FSH and LH secretion, leading to anovulation and scanty periods or amenorrhea. In the last, I would just like to point out that a lot of times when we see impotence or poor counts in males, we must rule out hyperprolactinemia in males also, because even in males, it works on the same pattern. It reduces FSH, LH, it reduces the testosterone formation, and it may cause decreased spermatogenesis. In fact, when I was going through the literature, I got this beautiful article by Dr. Abha only, and it's in Journal of Human Reproductive Sciences, where she has beautifully elaborated the management of hyperprolactinemia. And some of the patients, they don't tolerate the caboglin because of nausea and all. So this is another study, which is very interesting, because hyperprolactinemia, it works through kisspeptin receptors. So this scientist has
discuss the case now. I think we need to discuss the case, Aarti.
Absolutely, ma'am.
So
I'll stop sharing the slides. Yeah.
How was the menstrual cycles? How were they?
It was irregular. Like, she was getting her periods at the gap of 40-45 days with less flow.
So why did you give gonadotropins for ovulation induction?
Because, ma'am, because of her age, once we corrected her levels, and she had already undergone monitoring and it was not helping. So we thought that before, we to older age, we must stimulate her and give her results, because married for 7 years, trying for conception.
From the house?
Yeah. I want to ask that how long did the prolactin take to come to normal? I think I missed that.
In this patient, 6 weeks.
6 weeks, and you waited for 6 weeks, and then you started.
When the prolactin levels are very high or hypothyroidism is bad, normally I don't actively treat my patients, because otherwise the pregnancy outcome is also not good. So it's better that if we let the levels come back to normal, and then we can give them a better result.
I think
did your patient start getting normal cycles after your prolactin level came back to normal levels?
No, we didn't wait for that. For her,
didn't wait for that. I think, because you are saying that your patient was married for 7 years, maybe there was pressure on you to stimulate her. It seems to be justified. Otherwise, if you wait and the hyperprolactinemia is treated, the level comes back to normal, the cycles can become ovulatory on their own. And then
you don't have to give gonadotropins.
You don't need to give gonadotropins, but because the patient was married for 7 years, probably there was pressure on her to.
These were also not too good looking on ultrasound.
Plus, I think she was 38 also. So 38 is also
glad to have you back, ma'am.
I'm just logging out, but I mean, it's so interesting. I don't want to leave, but my calls are coming.
Ma'am,
you can give your last word, ma'am.
One important thing I want to say here is when we look at this, why in such a patient, honestly, I'm telling you, I would have started with 150 only. If I'm giving a gonadotropin, might as well give up properly only at 38. So I would have actually given up for 150 units and done with it. Because why you prolong 75 and then almost 19 days? If you think of it, her threshold was 150. From day 7, 150. In next 12 days, she was ready. So, I mean, I would think like that.
Aarti, I have response. Am I muted? Okay.
No.
And you have to be louder. Close to the screen.
I have a thing here. Why did you wait for 6 weeks to let her prolactin levels to come down to normal? You could have just
with hypothyroidism straight away.
If you were planning to give her gonadotropin, then you could have given right from day 1.
No, but she would require higher dose, isn't it, ma'am? If with
I allowed them to try naturally.
I think so, ma'am. With if you don't control the prolactin and go ahead with your, I would think so. And from my,
there is no difference. It is a situation of hypo if you don't correct it. If you correct it and you don't wait for normal ovulation, maybe a little lower dose, but she would have still needed the same, and she waited for another 6 weeks also. Ruma, what is your opinion? Tell us.
You're muted. You're muted.
Myself, yeah, ma'am. I mean, there is not much. The only paper that we came across on what levels, what effect the prolactin levels could have on implantation is from the late 90s. Yeah. And that says that high prolactin levels may not impact implantation. I think we still are waiting for a verdict on what its effect on implantation would be. But for now, we don't have anything to say suggest strongly that it's going to impact implantation. So perhaps you could give gonadotropins if there is an urgency, or if there is no such urgent need, maybe you need to wait for prolactin levels to come normal with bromocriptin, allow 2 to 3 months of spontaneous, after ovulation is established, 2 to 3 months of spontaneous trial. And if that has not worked, maybe move on to IUI.
I want to give a suggestion here, Aarti. I want to give a suggestion. The way forward to monitor such cycles are not doing a follicle monitoring. All you need to do is, if you've given capgoline or bromocriptine and you've monitored a serum prolactin level after 2 to 3 weeks and you find it coming down, then all you need to do is a weekly progesterone. And the moment you find progesterone has gone up, you know that she's ovulated. And all you need to do, once the prolactin levels do take 3 to 4 weeks to come down also at times, and you may have to modify the dose also if you find that they are not coming down. So a weekly prolactin followed by a weekly progesterone would give you a very good indication of that she has ovulated by this time. And once on that dose she has ovulated, she will get her menstruation after ovulation, say maybe 2 weeks later if she doesn't get pregnant. So that should be the constant dose which she gets for the next 3 months, and she should be able to conceive on her own. They do very well, but yes, gonadotropin is the way out if you don't have patience to wait for all that time.
We gave her 6 weeks. She was on the medicine.
And but you said you were doing follicle monitoring and you found no follicle. No,
that was before she came to us. That was before she came to us. We gave her 6 weeks, and
did you find out she ovulated or not in the 6 weeks?
We gave her, normally as a protocol, I give prolactin medicine and then I call her in next cycle only, and we tell them to try naturally, because suppose if she's coming to us on day 2, then after taking the medicine, I think second half of cycle, we don't do it every week. We give them, if the levels are very high, then we give them some time for the levels to come normal, and then we repeat it. That's what I have been following. Like,
what is the sometime? Sometime is like 4 weeks.
My sometime is 4 weeks for a repeat prolactin test.
Yeah,
that's what I have been doing. But maybe to save time next time, and then we let the patient try, because if the ovulation occurs, they can naturally.
Doesn't menstruation also give you an indication if she is, like you said, amenorrheic, irregular cycles? Then even happening of a menstruation would tell you that she possibly ovulated and then had her menstruation.
But hyperprolactinemia gives very good results with fertility.
Yes, pregnancy rates are much, much better than what they are with PCOS girls.
I want to ask Dr. Abha, ma'am, how long do you continue with Cabalin if she gets pregnant? How you stop it right away?
Of late, it is surprising. I got very few patients with hyperprolactinemia. I used to have a big series, and I sent a publication also 10 years ago.
Yeah.
But nowadays, there are rarely patients who emerge with hyperprolactinemia. I think they all go for egg donation and IVF.
Ma'am, I have a comment here, please. I have a comment here, Dr. Aarti. Dr. Abha had very nicely mentioned in her lecture when she gave that, serum prolactin levels need to be measured if the cycles are irregular and ovulatory. You just mentioned somewhere that you would like to do a serum prolactin level in all infertile women. Is that what you meant?
See, as a protocol, we don't do AMH for every patient. Now we are seeing other clinicians are doing, but FSH, LH, prolactin, and TSH along
part
with
of the regular workup.
Normally,
Dr. Abha, do you want to? Ma'am, do you want?
I would do prolactin only if she has irregular cycles, or we've been able to identify a anovulatory. Regular cycle means 32, 35 days bleeding, but the progesterone elevation was not there. So it is progesterone which directs us whether this hyperprolactinemia needs to be treated, and this does not. Because if she is ovulating and prolactin levels are high, say not higher than 100 nanograms, then in that case, we don't need to treat this high prolactin levels, because it is not causing any biological change in the patient. This is maybe the macro hyperprolactinemia, which is showing high levels in the serum without causing any biological activity and leading to anovulatory cycles.
Because Dr. Aarti, we come across patients who have a level of prolactin which is like 30, 35 and regular cycles, and still they are put on cabergoline or bromocriptine, so
that could be due to stress also, because unless you take proper pooled sample. My question is, so do we do day 21 for all progesterone to confirm?
I do that as a marker for ovulation in irregular cycles where I have not done follicle monitoring. I have no way to know whether she's ovulating or not if I have in doubt, because see, PCOS often come with intermittent bleeding, and they say, oh, I get a bleeding every 25 or 35 days. You don't know whether she's. I do a speculum examination to see her cervical mucus, and if the cervical mucus is clearly estrogenic, nothing. But if it is in doubt, then a progesterone.
But if we are doing monitoring and she has ovulated, then we don't need to do progesterone levels.
No, you don't need.
We don't have to do prolactin also.
But ma'am, you need to clarify, a infertile patient coming to the OPD, infertility patient coming to the OPD does not warrant a prolactin and a TSH level estimation.
TSH is yes, but not prolactin.
Not prolactin, ma'am. Even, and if she gives history
what is the other opinion, Niti? Do you do a prolactin regularly?
No, ma'am. I don't do it if the cycles are regular, and
no, I don't do it either. There are very clear indications for
doing prolactin. I don't do it.
Yeah. So if she's ovulatory, you don't need to.
Now,
and FSH and LH, what about FSH and LH, Ruma?
No, not as a routine.
Not as a routine. AMH is a routine.
AMH is
in cases of IVF or unexplained infertility or short cycles, perhaps. Yes.
Irregular
IUI patients lined up for IUI?
No, if you have to take a decision on whether you want to choose between IUI and IVF, perhaps you want to know how, and in a prolonged duration of infertility, you perhaps want to do an AMH. So AMH is again not necessary as a first step in the first visit. There are clear indications for AMH. There are clear indications for prolactin. These are not necessary investigations.
Because AMH is being done rampantly for all the patients. Somehow, maybe Dr. Abha can give a clear indication that if on TVS we see a good AFC, if ovarian volume is normal, we should not be ordering, like a regular practitioner should not be asking for AMH in all.
See, because I in fact feel that PCOS AMH is more important because it gives us, along with the antral follicle count, it gives us a very good idea of how easily the woman could get hyperstimulated. Otherwise, AMH only has importance when we are going in for IVF. In normal cycles who've come with infertility, where we are going to give ovulation induction, AMH is important in amenorrhea cases, it is important in IVF cases, it is important in the end of reproductive life type of
endometriosis,
surgery,
after surgery.
Any ovarian
surgery. Lots of questions. Can we take a few questions?
We have the last one, and then we'll have the questions. Let us have the
last. Ruma has the
last. I'll just quickly present this.
Oh yes. Sorry. Yeah. I would invite Dr. Ruma because the discussion,
Sorry.
Yeah. So I would invite Dr. Ruma Satvik to share with her case, and let's see what challenge she has to offer.
Yeah, so a lot of this has been discussed, but this be a reiteration of some key points that have been talked about earlier. And the case is of a 28-year-old lady who's been married for 2 years, has not been able to conceive yet. Her cycles are mostly on progesterone withdrawal, and when she bleeds, the cycles are regular, are normal flow for 3 to 4 days. She's been attempting conception for 1 year, and there is history of previous treatment failure with 3 cycles of clomiphene, out of which clomiphene and letrozole. So one with 50, one with 100, and one with 2.5 milligram of letrozole. The partner semen analysis, which she's carrying, is within normal limits. Now, we do a quick examination and we find that her body mass index is 33 kilogram per meter square. Waist circumference is 93 centimeters. Hirsutism, not really hirsute, but you could say borderline. Score is 8. There is acanthosis nigricans. The blood pressure is normal, 130/80, and the systemic exam is normal. Now, so we do order some investigations. An ultrasound reveals normal uterus and endometrium with normal adnexa. There are no adnexal masses. Ovarian volume of 10 and 12 cc. The antral follicle count is 14 and 18 on the right and left side. The thyroid and prolactin, which were ordered, are normal, and these have been done in order to rule out other causes of amenorrhea, or the kind of picture that she's presenting with. We have also ordered a fasting sugar, a 75 gram to our postprandial sugar, lipid profile, all of these in order to determine if there are any complications associated with her high body mass index. The FSH and LH values are displayed on the screen, 5.4 and 5.8. And an AMH has also been ordered in this case, largely to be certain that we are not dealing with any other case of oligomenorrhea or amenorrhea. So an AMH has also been ordered in this case because there is history of treatment failure with the usual ovulogens. So at this point, the question that would be posed to you is, what would be the case management? I could stop here, but I have 5 more slides. Do you want me to continue?
Yeah, you continue.
I'll continue. Okay. So now, of course, we more or less are certain that this is a case of PCOS and that the picture is not being caused by hypothyroidism, hyperprolactinemia, or any other cause based on the investigations that we have. And the first thing that was ordered was lifestyle management. Unfortunately, she could only lose 2 kgs in 2 months, and then she did come back desperate for conception. Now, because there is history of treatment failure with some oral ovulogens, there was option of trying 150 milligrams or higher doses, or there was option of giving her recombinant gonadotropins, which this is what we chose in the 3rd month from the 2nd day of withdrawal bleeding.
Just stop here, Uma. Let everybody guess a dose, what should be given for her. Yes, with 10 nanograms. I think it's very interesting here that all of us could just make a guess on the dose.
150. 150.
Just 50.
150.
I would just 50 for PCOD.
Oh, but she's a high weight.
I would start with, even if she's like 83, and I will start with 75 units.
I'll start with 50 units.
Great. I will start with 75.
I'll start with 50.
Yes, ma'am. So, I mean, a generation of teachers have been teaching us the importance of chronic low-dose step-up protocol in cases of PCOS with the high AMH levels especially. So where they tell us about how easily they can be overstimulated. And the idea is to prevent complications of OHSs or multiple pregnancies. And so chronic low-dose step-up protocol has been around since the 90s. And the idea was to start with a dose which will be low, continue it for a long time, and then step up in very small fractions of, which would be about 30 to 50% of the usual dose. And this was the idea. So here you can see in this, this is the treatment chart. This was on day 2. And the treatment dose that was started was 50 international units. This was given for 7 days totally. The picture on day 9 was this, that we recorded no change whatsoever, either in the endometrium or the sizes of the follicles. And at this point, the idea that after 7 days, we decided that we should step it up. And the dose that was then given was 75 international units. And so on, you can see that there is an increment in dose from 75 to 100 to 150 50 and it's day 22, you can see that there's very minimal change in the follicular cohort, actually none, or very minimal in the endometrium. The estradiol level hasn't risen whatsoever. And this is where we will ask the question, what needs to be done next at 150?
Anshu.
Yeah. So as you can see, ma'am, that she did not respond to 50, she did not respond to 75, and she did not even respond to 150 actually. So it's definitely resistant PCOS. Considering you have given it till day 22 and no response, it calls for cancellation of this cycle at least, because unlikely you are going to achieve anything out of this cycle.
All right.
Aarti, same.
Sometimes I call these patients again after 7 days, and sometimes they have 1 or 2 good follicles, and they may give us result. I have
7 days of giving what?
7 days. If she can continue with the injectables, that will be very good. But if the patient is really exhausted, like Dr. Jaideep said, that they don't want to continue, still I tell them, come after 5 days. Maybe once the stimulation starts, one of the follicles may be seen, and if we give them agonist, they may get pregnant. Dr. Jaideep says give LH.
Ma'am, this patient seems to be a case of FSH receptor polymorphism. So I think we should increase the dose of FSH. So we can even give a higher dose of FSH in her, and yes, we can add LH also.
But many times these patients will just start hyperstimulating also. That tip of
yes, it
you
happens.
Don't know. You don't know that.
It
so it's a little dangerous.
It happens in a bit. I'm just going to finish what happened.
Yeah.
So I take all the points. Dr. Anshu's point on that it can be cancelled depending upon the patient's mood. I take Dr. Aarti's point that you could extend the stimulation for some more days. Some people, we don't know how many, but some people might make it to the next stage where they will attain a dominant follicle. And Dr. Neeti's point that perhaps you need to step it up. So one of the three, I'm here to tell you what we did in this case. So here, day 22, we started giving her HMG. That was the switch that was made, and the dose was increased. So after giving 225 for 5 days, from day 22 to 27, this is all counseling and all of that is happening. And the patient, you can see, has already had 3 treatment failures. And to announce that this is another 4th treatment failure, I think it was very easy for her to say, okay, go on and see what you can do. So this is what we have done. And so you can see the follicular cohort has risen from wherever it was to this. So now we have reached a stage of sudden increase in follicle sizes from 4,455 to 12, 11, 11, 10. And you can see, and this is the point perhaps to step down the dose in order to avoid the complications of hyperstimulation, which was stepped down to 150. And then again, this dose was continued because on day 31, you can see that only 4 follicles have taken the lead and they will need to be sustained. Hence, the same dose is being continued. On it's written incorrectly here. It's not day 17, but whatever the final day was, you can see that 4 follicles are there. And again, you need to counsel the patient once again. This is perhaps the first time that she's made these 4 follicles, that she's going to ovulate. One doesn't know, perhaps the first time. And the chances of multiple pregnancies, not OHSs, but multiple pregnancies in this case is very high. And a very high level of caution has to be exercised at this stage. High level of caution in alarming her about multiple pregnancies, the chances of which are about 25 to 30% in such a case. If she, despite that, she says, I want to go ahead, you would want to probably trigger and allow her a timed intercourse. Otherwise, you say, just cancel it, avoid intercourse also. So you can see this is what we did. There are just 2 points that I'd like to add here. That one, she responded to HMG in a higher dose, and this is after the recombinant, which was started from 50 in escalating doses till 150. We had no response at all. The questions that we are raising here is, what was the starting dose of gonadotropin optimal?
Yes.
Why did she? No. Yeah, that's good. Why did she not respond to the incremental recombinant gonadotropins despite high AMH? And was she more responsive to HMG than to recombinant FSH are the questions that we are trying to answer. I'm quickly going to the discussion. So starting dose in obese, and this is the distinction we have to make, that all PCOS again are not one category. You make that distinction between obese and non-obese, irrespective of what their AMHs are. So here there are several papers that ask us to make that distinction. So the first one has made that distinction based on 25 kilogram per meter square, where they talk about a recombinant, the starting dose of 50 versus 75. Here our lady is 33 kilogram per meter square. So clearly 75 or more would have been more appropriate. And then again, papers from the past would say that the starting dose has to be higher in obese PCOS. Yes. BMI becomes an important way to determine. And this is a very lucid, although a little confused, but I would say something that everyone needs to maybe click and download somewhere. So there are 5 levels at which you are making this decision. First is whether this lady is a PCOS or not. You say she's a PCOS. You come down to her age, less than 30, 30 to 40, 40 to 45. Less than 30, let's say the standard dose is 75, but you have to individualize then based on AMH. So 75, we come down to AMH level at baseline 5.1 to 10. That's the category. You subtract minus 25. But look at level 4. What is happening? BMI less than 25, you should have subtracted more 25. So actually the dose would have been, starting dose would have been 25. At BMI 30 to 35, this gets nullified, the AMH level. So your starting dose should have been 75 perhaps, or maybe 100, depending upon. So in this case, maybe 100 would have, that would have been my starting dose, or 150 HMG would have been my starting dose. And then if there is a history of moderate or severe OHSS in previous cycle, you again reduce the dose by minus 25 to 50. So those are the 5 levels at which this decision of what dose to start with is taking place. And starting dose is extremely important in such women. So, however, there is this paradox of high AMH, and you could question why did a woman with 10 nanograms of AMH still did not respond, and why was the response suboptimal? So we do know that through our physiology lessons that FSH is acting at the level of, you can see small and large antral follicle, where it is preventing cyclic recruitment. This is what AMH is doing. AMH is preventing the FSH induced cyclic recruitment of small follicles to antral follicles, and that is kind of increasing the follicular threshold, FSH threshold level of follicles. So they just need a higher FSH value to be stimulated. But when all of them do, they suddenly bloom up, which is why the need to step down in these cases. And here we are trying to talk about that this is a clinical study which has come up very recently, as recently as 2019, which is talking about how you could individualize the dose. And this is a very stark finding that I only bring this about to show you this picture, which is talking. So the first panel of 3 bars that you see are the people who received FSH dosing based on an individualized AMH based individualized FSH dosing. The second panel is standard dosing. Okay, now each of these bars are divided into black, light gray, and dark gray. The black gray, the idea was to give them a dose such that their oocyte recovery in IVF would be between 5 and 14. That was the intended thing. So you can see that when you individualize doses based on AMH, when the AMH levels were high, the bottom panel in the x-axis is showing 24 to 40, which is roughly equal to 5 to 7 nanograms per ml AMH. You can see that when you individualize, because you thought that AMH is going to suddenly cause a bloom in the response, and you reduced your doses, see what is happening, that the oocyte recovery, that is, which would be, is low. So less than 5, the proportion of women with less than 5 oocytes is much higher in such women. So higher proportion of women with higher AMH had lower oocyte recovery when given low dose gonadotropin. So AMH alone cannot be a determinant, is what I'm trying to tell you. There will be multiple factors. One was BMI, second is very high AMH causing a suppression of FSH induced recruitment of follicles. And finally, we talk about gonadotropin receptor polymorphism, which was raised. And the center has this paper on, this is not an isolated case. There have been 18 such cases where they were resistant to normal gonadotropin stimulation. They were resistant to clomiphene ovulation, and they were given high dose HMG in which they responded. And the significant factor in this, there were 3 or 4 significant points that were raised by the authors. One was that their BMI was high. The average BMI was above 30. The second was that the AMH was high. The average AMH was above 80 picomoles. And so those are the 2 factors, again, that are acting up in these 18 cases. To prove that this is a gonadotropin receptor polymorphism, one would, of course, have to undertake genetic tests. But one little point that I'd like to add is that if you presume that this is a gonadotropin receptor polymorphism, which is that they are resistant, the receptors are resistant to the action of FSH partially, the FSH level should be slightly higher. They cannot be low. So if they are sort of normal or in the range that normal PCOS women have, it is generally less likely that this is a gonadotropin receptor polymorphism. And that's my submission in this case. Lessons learned.
Very good point raised, Ruma, because we kept wondering when we did the FSH polymorphism study, which one of our fellows tried to do, and we couldn't complete that study, but we could find no correlation with the Posidian group 1 and 3 and
louder, we can't hear you.
Polymorphism.
I'm
So
louder.
that is one thing, that it could just be what you're saying. We should have looked at the FSH levels baseline, and that could have given us an indication that is it going to be a resistant type of case or a normally high responder, which PCOS are.
So lessons learned, BMI is an important determinant in deciding starting dose, equally important, as important as AMH. A very high AMH can paradoxically inhibit FSH action. And HMG might be a better gonadotropin in a very small subset of PCOS women. And these women may have, and we are not able to prove it in this case, but may have, this is something that you could keep in mind, but it is not as frequent as we make it out to be. Number 1 and number 2 should be primarily on your mind. Number 3 should be low down on your list. Either require high doses of FSH or require LH addition. I'll end it here. Thank you.
So the house is open for discussion.
I want to ask you that she had so many small follicles. You know, she had so many of them in the beginning when before the dominant follicle came up. What became of those, and how come she never had hyperstimulation? I'm sure she must have had mild OHSS at least, because what became of those small follicles?
May I just ask the organizers to help me stop sharing my screen because I can't see.
No, it stopped.
It stopped. It stopped.
Okay. I couldn't see anybody.
It stopped. It stopped.
What's your question again?
The small follicles, there were so many of them when you were stimulating and not getting any results. And suddenly when those 5 came up, what became of those small ones? Because they are going to give you trouble. I'm surprised what became of them, and did this patient land up with mild OHSS at least? Because she's obese, she will be able to tolerate the OHSS better.
So if you see, there was a step down in the dosage, number 1. And the smaller follicles, so just to answer your first question, and then there will be a second answer. The step down, what it does is the less sensitive follicles will stop growing any further because they have not developed mechanisms of what is known as, being on the auto mode, so that even in the presence of small FSH, they can continue to grow. So the others, although they look 11 mm and 12 mm, they perhaps would have stopped growing, stopped secreting estradiol levels. To answer the second question, is you are right that mid-sized ovarian follicles are the ones that are most responsible for OHSS. But as much as I know, the size, the follicular sizes studied are between 12 and 14 or 12 and 15 mm. Those are the sizes.
Not really. 8, 9, 10, all of them are troublesome actually when it comes to OHSS. So actually you need to take care of those when you are,
I think it's 11 to 14. That is based on several studies.
Here, if you were stimulating her for IVF and you would have kept the dose constant, then it is all these small follicles which would go on crossing the threshold and they would give you a severe OHSS. But the moment you start stepping down, even in IVF, when you step down, a lot of times you get very few follicles from these smaller follicles, which in cases where you've kept the dose constant, you still get oocytes from the smaller follicles. You understand? So stepping down is the key before. But yes, you are right that in case there would have been 4, 5, 6 dominant follicles, we would have to cancel these cycles. And
Yeah.
out of these 18 cases, almost half the cycles were cancelled. So we could not go ahead with allowing them to have a sexual intercourse because we were afraid. We did not give them a trigger. We just left them to themselves. And when you have a lot of follicles and you don't give them HCG, then the LH surge is not enough to sustain all the follicles. A pregnancy doesn't happen and the luteal phase crumbles much faster. You understand? So all I'm trying to say is that you can get follicles on the cost of having a multifollicular response in such patients who are high AMH, and maybe indicators like basal FSH, body weight, very high AMH can give you an idea, and the age, especially that big chart which Ruma showed, should be a guiding factor to us, that what should be the ideal dose to start gonadotropins at. Because if you just look at AMH and the antral follicle count, you will definitely start with a very low
Lower
dose.
dose. Yeah.
You will never dare to venture for ovulation induction with a higher dose. And when you increase gradually, like we normally do, then we lose the cycle somewhere, because these endometriums don't grow, the patient may bleed, or the cycle just goes on and on and on with low estradiol levels. The moment estrogen rises, the endometrium rises. But then a lot of these cycles have to be cancelled, and that is why these patients, if 2 such cycles go on, then we counsel them that, maybe IVF is a better choice, because we can't stimulate you with lower doses, and the moment we go on higher doses, you tend to overstimulate.
Yeah.
So you have to very judiciously go ahead in these cycles, cancel them if need arises.
Yeah.
Ruma, only one comment. You mentioned that you left her for natural contact, this patient, no? So why give her SCG? So that the fear of OHSS also goes, which Dr. Anshu has. So why was
Very
HCG
important.
required?
Exactly. My next question was that only. Why HCG?
Sure, one could avoid that. One could avoid that. One just feels that the entire pituitary is so, I mean, this is just a personal thought, that it's so deranged that, so many kinds of stimuli are not working. Perhaps you need to do something in order to kind of.
I will give you an answer for this now, Anshu. The reason is that up to 2 follicles, a natural LH surge can support the luteal phase and the corpus luteum which forms. But more than 2 follicles, if are there on the ovarian surface, then the LH is not enough to support them through the luteal phase. They will undergo luteolysis. They will spoil the endometrium for implantation, even if there is a possibility of an embryo roaming around over there. So if there are more than 2 follicles in any type of stimulated cycle, then probably they need a small dose of HCG to support the endometrium. Even if you leave them on a spontaneous LH surge, it would be wise to give a smaller dose of 1000 or 1500 HCG, because there are many follicles and LH cannot support all of them. They will crumple down and they will release cytokines which will spoil the endometrium, however much you have tried.
Why not an agonist trigger, ma'am, in this patient?
To these patients.
Why not an agonist trigger rather than HCG?
Agonist trigger is very good, but then you'll have to continue with everything. You will have to give aggressive luteal support, which means HCG.
That's true, but that's better when you are dealing with at that level.
Yes, you can do that. We only gave HCG when we thought that we can maintain this cycle. Otherwise, we just had to stop doing everything for the cycles when we got on the surface more than 3 dominant or 4 dominant follicles. So then you give estrogen and you give progesterone and you give a small dose of HCG for luteal support, and still there would be luteolysis to some extent. But yes, that is a good option with aggressive luteal support then.
Yeah.
The dose would have been less. That means like we had given 5,000 units in this patient. So
That's deliberately reduced.
You could have given a lower dose. Our learning continues. So instead of giving a GnRH agonist trigger, which we do in IVF, because we are not afraid of the endometrium, we're not going to transfer in that cycle. And rarely we do need to give aggressive luteal support where we don't have embryos to be frozen, or we have very few embryos, compromised embryos where we don't want to freeze them. Then we give aggressive luteal support. But lower HCG dose is very much in line for these patients, and maybe 250, 2500 could have been a dose, or a agonist trigger with 1500 or 1000 HCG with estrogen, progesterone, everything could have been given. Your opinion, Ruma, you presented.
Yeah.
Ma'am, can we quickly
have
take
done
few
that also.
questions, because there are lots of viewers, more than 700 viewers with us, and they have posted lots of questions. So can we quickly
the
take
questions? Do we have time?
Yeah, just 5 minutes, 2, 3, because I've got so many questions, maybe, the difficult ones, because otherwise with this discussion, most of the queries have been solved, and I'm sure everyone must have learned a lot of new points. So I'll be very fast. How would you manage a 37-year-old normal hormone parameters with regular cycles but oligomenorrhea with patent tubes? Counts are normal.
Regular cycles with oligomenorrhea doesn't go together. Something's wrong.
So that's what the question is posted. We have got it from audience. This is from Dr. Chizara Okiki. I mean, looks like to be a Japanese name to me. So she has written that she has regular cycles, but less flow and tubes are patent, counts are normal. And she has had previous 3 biochemical pregnancies, aborted spontaneously, APLA came normal. So what should we do for the next pregnancy?
The house?
Oligomenorrhea as such, I don't
Not oligomenorrhea, hypomenorrhea. I just correct it. Hypomenorrhea.
Yeah.
So what is her uterus like, the endometrium?
Endometrium, she has not commented. Maybe we need to check her cavity also.
So one needs to make that distinction. If this is a low flow issue that we are dealing with, a low flow issue could have to do with the uterus more than anything else. And so perhaps maybe are we dealing with Asherman's here, or are we dealing maybe a simple ultrasound and endometrial, mid-cycle endometrial thickness should be able to tell us that. Yes. But apart from that, I think after 3 pregnancy losses, one could initiate the workup of recurrent pregnancy losses, which would include karyotyping, husband and wife. It should include APLA. Here comes the role of APLA. Yes, inherited thrombophilias. And apart from assessment of the uterine cavity, is there a septum sitting there? Is it Asherman's? What is it really?
Mid-cycle
inherited thrombophilia are no longer included in recurrent pregnancy losses.
Yeah, you are right, Dr. Anshu.
Yeah.
Yeah, it is not no longer
now left behind, and it's not really required. So I don't agree with that.
Only for second trimester losses. Only for second trimester losses.
I think you're trying to say this about acquired. Inherited.
Inherited is not required.
Yeah, I never mentioned inherited. I mentioned acquired.
You did by mistake.
APLA is what I said.
I think ultrasound, mid-cycle ultrasound should clinch the diagnosis to quite an extent. 3D ultrasound.
The hysteroscopy also.
Yeah, exactly.
Your HSG to assess the cavity. Quickly coming to another question. How to manage luteal phase defect with hyperprolactinemia? Should estrogen to be given in cases of hyperprolactinemia?
Neeti, you answer.
Yeah. You have to answer that.
I think my attention span has gone. What was the question?
Estrogen can be given in these patients. There is a review of literature which says estrogen can be added to progesterone in patients who have hyperprolactinemia, and a good progesterone support. I think that's my answer to it.
Yeah. Well, I don't think that this should be done. If she has hyperprolactinemia and she has a deficit luteal phase, first thing is how to find out a deficit luteal phase is by doing a mid-luteal progesterone. And if the progesterone levels, now there are various levels which are defined to say that this is normal. Anything more than 5.6 confirms ovulation, but over 8 nanograms says that this is a good luteal progesterone. What is the length of the luteal phase, which means from the day of ovulation to the next menstruation? If that is normal and the progesterone is normal, then the luteal phase is not deficient. So she has to identify, and if she still feels it is deficient, then progesterone should be the best answer to it. Or if it is really associated with hyperprolactinemia, then capgoline or bromocriptine can be given to this woman.
Last one, I think very interesting one. She has asked what can be done to, what can be used to increase ovarian reserve in women over 40?
Nothing. Unanimous answer.
Don't be so disappointing to other viewers. I think we should add something at least.
No, nothing.
So another small question, simple question. When do we add steroids in ovulation induction? In case we don't see any dominant follicles growing, I don't think steroids have a role.
No.
Only if the DHA is
congenital adrenal hyperplasia.
Yeah,
and if DHA is high, then you have a role for giving steroids.
17-hydroxy progesterone is high, then there is a role.
Yeah.
steroids otherwise.
When the adrenal source is there, then you need to.
So what is the status of tubes in Dr. Ruma's case? That's what Dr. Sujata wants to know.
I'm glad that question was asked,
Yeah.
and I would like to answer that. So this is a lady who's never ovulated, all right? And you don't want to check the tubes as a first measure because she has not had the opportunity to conceive yet. Even when we start investigating a case of infertility, it's the non-invasive tests that you want to first prove. And once you have that, you probably want to correct that. So HSG as a first measure in such a case is not to be ordered. If after repeated ovulatory cycles, she has been unable to conceive, that is when you start testing or maybe suspecting the tubes, not as a first measure.
But my question is, if you're taking a case for induction of ovulation, you are giving her injections for about 20-25 days, and she is going to spend good few thousand rupees on the induction. Isn't it justified that we confirm the tubes? Because I get to see a lot of patients.
This is the second part of the whole coin, that ideally you don't look at the tube. Maybe in the second cycle, ovulation induction, we would want to see the tube.
If there is no history suggestive of any involvement of the tubes, perhaps you can forego that investigation.
So,
but I think after one cycle, Ruma, we can consider checking the tubes because she's taking so long to, ovulate.
Frustrating.
This particular patient.
And a big thanks to Dr. Abha and her team and Dr. Anshu Jindal.
And Dr. Aarti, it was such a good program. We really enjoyed.
Yeah.
I love to have all the panelists, Anshu, you, Ruma and Neeti. I felt as if we're doing a class.
Yeah.
So nice to interact with Dr. Anshu. Nice, interacting with you, Dr. Anshu.
Thank you, Neeti. Thank you, Ruma. Thank you, ma'am. Thank you, Aarti.
Bye-bye.
Bye. Have a good evening.
Thank you, Aarti. Bye.